Good morning, my friends and my fans and my colleagues. Today I will speak about the hepatorenal or the reno-hepatic relationship, or the relationship between the liver and the kidney in clinical practice and in pathological involvement or in disease. The relationship between the kidney and the liver actually, or in reality, is a complex process and is bidirectional and is extremely complicated. How does the kidney react to liver disease, and how does the liver react to kidney disease? This is my focus and my topic. In clinical practice, liver disease as a complication of renal disease is rather less common, or I will not say rare, or it's rather uncommon, but the renal complications of liver disease are much more common. But let us say that the relationship between the liver and the kidney in disease can be one of two categories. Either the patient has a primary liver disease and then gets renal complications as secondary features, or the opposite, that is the patient has a primary kidney disease and then gets hepatic complications or secondary hepatic manifestations. Both the kidney and the liver are involved as a part of systemic disease, and they either present concomitantly or they present sequentially. That is, the systemic disease first involve the kidney and then involve the liver, or first involve the liver and then involve the kidney, or it presents in clinical practice to the clinician with both manifestations of hepatic and renal involvement at the same time, that they are coexisting. There is coexisting hepatic and renal manifestations at the same time clinically. Whether this is regardless of whether the pathology started in the liver and then the kidney, or started in the kidney and then the liver, but in reality, in practice, they presented as together at the same time with both renal and hepatic manifestations, symptoms and signs. Firstly, I will talk about the systemic causes which involve both the kidney and the liver simultaneously, and the patient may present with both renal and hepatic manifestations, and both liver and the kidney disease coexist in the same individual, or in the same case, or in the same patient. Among those diseases, systemic disease with both liver and renal involvement, are diabetes, the well-known chronic endocrine metabolic disease, the diabetic syndrome. Diabetes mellitus, especially type 2 diabetes, it can affect both the liver and the kidney. Of course, the diabetes affects the liver by what we call the fatty liver disease, and this is the commonest way the diabetes affect the liver, the diabetic fatty liver, or what we call hepatic steatosis, or in severe cases steatohepatitis, which might progress into some form of chronic hepatitis and liver cirrhosis, that is chronic liver disease, especially in advanced uncontrolled diabetic patients, and especially in diabetic obese patients, or what we call the diabesity syndrome. So the fatty liver disease, or the NAFLD syndrome, or the non-alcoholic fatty liver, is more common in diabesity, that is diabetes with obesity, rather than in diabetics who are lean weight or who are not overweight or obese. So diabetes can cause non-alcoholic fatty liver disease, and at the same time, of course, diabetes can involve the kidney with what we call diabetic kidney disease, or diabetic nephropathy. Diabetic nephropathy is a well-known manifestation of microvascular disease, or microangiopathy in diabetic patients. We all know diabetes causes macroangiopathy, coronary heart disease, cerebrovascular disease, and peripheral vascular disease, and microangiopathy in the form of nephropathy, retinopathy, and neuropathy. Nephropathy is a part of the diabetic microvascular complication spectrum, the diabetic kidney disease or the diabetic nephropathy. The kidney is commonly involved in type 2 diabetes also, as well as, of course, in type 1 diabetes, although the pathogenesis is different, but also it is a target and is a complication in diabetic patients of the type 1, as well as other diabetic classes or the other diabetic syndromes or diabetic classes or other causes of diabetes, like in the Modi syndromes, for example, maturity onset diabetes of youth, and another form of diabetes. These are all types of diabetes, but I focused on the type 2 diabetes and the kidney involvement in type 2 diabetes, the diabetic kidney disease. So this is diabetes, is a systemic disease which might involve both the liver and the kidney. Also, amyloidosis, it is a metabolic disease characterized by, and we have many types of amyloid, primary amyloidosis, secondary amyloidosis, and the amyloid characterized by the position of some abnormal protein called amyloid protein in different organs of the body. It might be localized or might be systemic, and if in the systemic form, and of course it can complicate many problems like chronic infections, chronic inflammations, chronic intoxications. Some endocrine conditions can be complicated by amyloidosis. Serious chronic infections can be complicated by amyloidosis, and this amyloid can deposit in different organs of the body, and among these organs which are commonly involved by amyloidosis are kidney and the liver. So we get hepatic amyloidosis and we get renal amyloidosis in the same patient, and this might lead to further complications later on in the kidney. It will or it might progress into renal failure. In the liver it might progress also into functional impairment and liver cell failure in advanced cases, because it destroys the organs, that destroys the liver and ultimately also destroys the kidney. So amyloidosis is a systemic disease which involves both the liver and the kidney at the same time, amyloid. A third cause also, and common cause, is the lupus. Lupus can affect the liver. Of course, lupus affected the kidney, and it is one of the target organs of lupus, the kidney. We all know that systemic lupus is a collagen vascular disease, a systemic vasculitic problem involving the small blood vessels, and it causes microvasculitis, and it is related to the disturbance of the immune system. There is an organ non-specific reaction which might attack the kidney, causing lupus nephritis, the brain, lupus cerebritis, the joints, of course, with arthritis and arthralgia. It can also affect the skin, can affect the hematologic system with anemia, thrombocytopenia, the pancytopenia, and leukopenia. It affects the skin with its various manifestations, lupus dermatitis and the discoid lupus and the rashes and the different cutaneous lesions in patients with lupus erythematosus or SLE. So lupus is a disease which commonly targets the kidney and causes glomerulonephritis or glomerulopathy, and with all its spectrum, membranous, membranoperative, mesangiocapillary, etc. Different types of glomerulopathies in patients with SLE or systemic lupus erythematosus. So the kidney is a common target in females, because this disease is more common in females or in ladies, the SLE, like other collagen vascular diseases. So SLE affects the kidney, and also at the same time it might affect the liver with abnormal liver function tests due to drugs, most commonly drug induced. The drugs which we use them in SLE, they secondarily affect the liver. So if we find abnormal liver function tests in patients with SLE, this is most probably related to drug effects or related to maybe a secondary infection with hepatitis B or C, or maybe due to some form of hepatic granulomas or granulomatous hepatitis in patients with SLE. So this is the systemic lupus erythematosus might affect both the liver and might affect the kidney also. Also, sarcoidosis is another example of a systemic disease of unknown etiology, and the sarcoid is characterized by non-caseating granulomas, and these granulomas might affect the liver and might affect the kidney, and we get renal sarcoid, for example, and the hepatic sarcoid. Sarcoidosis can affect the liver and the kidney, in addition to, of course, the more commonly affecting the lungs and the respiratory system and the mediastinum and the lymph nodes and the joints. It's a systemic disease. As we all know, sarcoidosis is a systemic granulomatous disease with non-caseating granulomas as a pathological feature, and it might involve different organs and systems in the body, including the lungs, including the liver, including the kidney. So this is also another systemic disease. So I mentioned diabetes mellitus, I mentioned amyloidosis, I mentioned lupus, I mentioned sarcoidosis. These are all systemic diseases which might simultaneously affect and involve the kidney and the liver at the same time. They might be involved simultaneously or sequentially, but ultimately the renal and the hepatic manifestations will present in clinical practice, and they will coexist as a part of the clinical presentation in the patient. These are the systemic causes involving liver and kidney at the same time. And then we come to the renal complications of liver disease. One of the commonest forms is the hepatorenal syndrome. And the hepatorenal syndrome, I will talk about it in a different mini lecture or presentation because it needs a little bit more details, the hepatorenal syndrome. And the hepatorenal syndrome is a form of progressive renal failure in patients who are having advanced cirrhosis with ascites. And this hepatorenal syndrome, renal failure in advanced cirrhotic patients, advanced patients with liver cirrhosis, usually with ascites, and in the absence of any structural kidney disease and in the absence of shock, because this type of renal failure in chronic liver disease patients or in chronic cirrhotic patients, which we call it the hepatorenal syndrome, is in fact a functional renal failure, not a structural renal failure. There is no structural damage to the kidney, but it happens due to a severe circulatory dysregulation, which affects the kidney, and ultimately to a functional acute kidney injury in the absence of any structural damage and in the absence of any of the causes which might lead to pre-renal, what we call pre-renal failure, like hemorrhage or sepsis, hemorrhage due to a ruptured esophageal varices, for example, leading to hypovolemic shock due to hemorrhage, or what we call hemorrhagic or hypovolemic shock. This will cause another type of renal failure in patients with chronic liver disease, because renal failure might be pre-renal, renal, or post-renal. The most common categories of renal failure in patients with chronic liver disease, either pre-renal due to pre-renal factors, most commonly sepsis or loss of fluid or loss of blood due to bleeding. That's hypovolemic, or sepsis due to complicating infection. And the other type is structural due to acute glomerulonephritis, developing in the context of liver disease, or to acute tubular necrosis, which is most commonly either toxic or ischemic. And the most common toxic is nephrotoxic drugs like non-steroidal anti-inflammatory drugs and aminoglycosides and gold and dipenicillamine and heroin and pamidronate. These are nephrotoxic drugs which might lead to toxic acute tubular necrosis, and here this is an intrinsic acute structural renal disease. But the hepatorenal syndrome, with its definition, it is a functional failure, not a structural failure, and it happens in the absence of structural kidney disease. There is no macroscopic hematuria, there is no macroscopic proteinuria. The proteins, if present, is not more than 500 milligram per day, and there is also normal kidneys on renal ultrasound. These are preconditions important to be fulfilled for as a part of the diagnostic criteria of hepatorenal syndrome. It is a functional renal failure due to severe circulatory dysregulation in patients with chronic liver disease due to inability to detoxify the toxic metabolites, which are vasodilators. So they lead to splanchnic vasodilatation and reduction in the mean systemic arterial pressure, and then with the compensatory release of catecholamines and vasopressin. That's why this type of failure, it happens in chronic liver cirrhosis, usually with ascites and or almost always with ascites, and is usually associated with hyponatremia due to excessive release of vasopressin in such patients as a secondary phenomenon. There is secondary hyperaldosteronism as a compensatory mechanism due to activation of the renin-angiotensin-aldosterone pathway and activation of vasopressin release, leading to water retention, free water retention, and hyponatremia. So hyponatremia and ascites characterize part of the clinical picture of the hepatorenal syndrome, which, again, I repeat, is a functional renal failure due to severe circulatory dysregulation in patients with severe liver disease, usually chronic liver cirrhosis with liver failure and ascites. This is the hepatorenal syndrome. Then I will talk about the other associations between the liver and the kidney in my next presentation. Thank you so much, and let us meet in the next mini presentation.